So this is a 54 years old male, known case of diabetes hypertension, now presented with 6 hours of chest pain on ECG, has a ST elevation in anterior leads V1 to V6, and this is the angio, and this is a levocaudal view, and you can see there's a 100% total occlusions, thrombotic occlusions in the LAD, and there's a lesion in the L6 also. You could see the LAD is totally 100% occluded with thrombus. And to our surprise, this patient presented with ST elevation in V1 to V6, and this is the RCA. This is osteoprox total thrombotic occlusions in the RCA also. So this patient admitted in the Yojana, which has only 2 stent. So patient has a continuous chest pain, so we decided to do the plasty to RCA and LAD. Meanwhile, patient had one episode of VT, and then we have given the one DC shock with the 150 joules, and patient reverted. And this is the temporary pacemaker lead, you can see under the coverage, because there was osteoprox RCA block. And this is the BMW PTCA wire. This thrombus was organized, and after 5 to 10 minutes this wire has crossed in the LAD, and this you can see the LAD. Distal LAD was like very thin diseased, and because this patient had uncontrolled diabetes, he on presentation he had a sugar of 500, GRBS of 500. He was a drug defaulter for the diabetes, and this is the picture. So this is the areocranial view. We decided to put a stent in the thrombus portion. So this was the stent placement, and then we deployed the stent in the proximal to mid LAD where the thrombus was there. And this is the scene after the placing stent deployment, and you could see the distal LAD was thinned out, thin vessels, because the patient is uncontrolled diabetes, and it has multiple lesion. You can see the diagonal and all. Everywhere he has a thin disease, thin vessels and disease. But we had to open this because patient had a continuous chest pain with 6 hours of index pain, and patient had one episode of VT, and during stent placement he had again one episode of VT. We have given the shock again. This is again the areocranial view after the stent, and you could see how diffuse disease, how small caliber vessel in the LAD distal. Meanwhile, on ECG there was a CHB, but the temporary pacemaker was there. So this is because of osteoprox occlusion of the RCA. So we engaged with the JR to RCA, and we tried to cross the whisper wire. It was organized thrombus, but somehow crossed the wire. So this is the picture after crossing wire, and we tried to put a stent without predilatation, but stent was not going in the proximal part, so we had to predilate the lesion because it was the acute condition. We didn't want to spread thrombus here and there with predilatation and all, but here we didn't have any option because the thrombus was organized, and then we predilated. This was a serial predilatation, and then we took a stent of 2.75 into 32, and then from the ostium of the RCA we deployed the stent at 12 atmospheric pressure. Meanwhile, after deploying stent, again the patient had a VT, and then we given the shock, and BP fell down, and this was we opened the RCA. So we had only 2 stent for this patient in this Yojana. So we opened the RCA and the LAD. Now somehow patient settled, BP got up. Now BP is 120/80, and he has his own rhythm at 100. Temporary pacemaker we have kept at around 80. So this is the primary sort of angioplasty to LAD and RCA. Both were 100% totally occluded, thrombotic occlusions, and he presented with the ST elevation in the anterior lead. So that is how we saved the patient, this patient. Now patient is stable. We are shifted to ICU.